Joining us today is Dr. Ian Scott, Director of Internal Medicine, Associate Professor of Medicine, University of Queensland, who'll be speaking at IIR's Reducing Hospital Readmissions and Discharge Planning Conference on the 26th to 27th of July in Melbourne. Hello Ian, thanks for joining us.
Thanks, James.
Firstly, how can you predict if a patient has a high likelihood of unplanned readmission?
Well, you can use a number of patient factors that have been associated in a number of studies with a much higher likelihood of unplanned readmission. They would include things such as age of patient. The older the patient, the more likely that they might be readmitted. People who live by themselves with little social support, for example. People who are on multiple medications also more likely to come back because they have medication problems, and certainly more likely if they've had a change in medication during their admission with perhaps inadequate counselling or education as to the need for the change and why they should do it. If they've had previous readmissions in the past 12 months, they're also more likely to be readmitted. If they have problems with cognitive impairment, and if they have social isolation and poor social support, that also puts them at high risk. So there's a number of factors that people have identified as indicating a high risk of readmission. Some folk have tried to put these factors into some sort of risk prediction rule that you can apply during the admission and perhaps try to identify a cohort of patients at high risk of readmission, but unfortunately they don't tend to predict that well. They don't necessarily pick up all the people who are readmitted, and they include a lot of people who actually do not have a readmission subsequently. So the desire to be able to predict accurately who's going to be coming back unplanned readmission in the next 28 days is not as exact as we would like it to be, but nevertheless we are aware of factors that certainly are associated with a much higher likelihood of readmission.
And what are some of the problems in the quality of inpatient care that increase the risk of unplanned readmission?
Yes, well, I guess from the factors I've just mentioned, you can associate a higher risk of readmission with, for example, inadequate counselling education of patients as to what they need to do when they go home, why some of their medications were changed from when they came in, and the importance for them to make sure that they now adhere to the new treatment regimen. Certainly studies have shown that if carers and families also are not fully appraised of what happened to their relative while they're in hospital and what they need to do also to keep an eye on their relative, that increases the risk of readmission. So counselling education of carers and relatives is important, particularly as many of our patients in hospital now are fairly elderly. I think a lack of coordination between the hospital and any community health services, between the hospital and general practitioners. In other words, other health care providers who will need to be involved in providing ongoing care once the patient returns home. If they're not fully aware of what's happened while the patient's been in hospital, what the follow-up plan is, what aspects of care they're responsible for, that also can increase the risk of readmission because the whole system falls down because of lack of communication. So sort of guiding people through that transition of care from hospital back to community and making sure that all the relevant members of the healthcare team are aware of what's going on, and also need to understand when patients should be referred back if they're showing signs of any deterioration, or if they need to have some further a review by a doctor in relation to the care, any aspect of their care plan. Then if that's not available, then patients then often can bring themselves back simply because they know the hospital was there when they were admitted, and if they have a problem they feel that they can simply just go back there again. So I think that's probably the most important aspect, is to make sure that there is a discharge plan, that there is adequate education and counselling of patients, carers and relatives, and that external care providers, GPs, community health services, domiciliary nurses, etc., are all in the circle as to what's going on.
What are some of the other strategies that exist to reduce the risk of unplanned readmission?
Well, I guess that people have looked at a couple of things. A lot of things have been tried. Not a lot of things work, unfortunately. There's been a number of interventions that have been studied in various studies over the years in relation to transition coaches, discharge plans, case management, trying to identify high-risk target group for home visits and other interventions once they go home. The literature, unfortunately, it hasn't come out with a strong message that any one intervention works, but I think what we are seeing is that there is evidence that if you have a multifaceted strategy which involves a very detailed assessment of patients' functional and physical capacity when they're in hospital, and a full appraisal of all their various comorbidities, as well as the acute complaint that they've come in with. And if you combine that with an individualised care plan, and that there is a discharge coordinator or a nurse or some person who takes control or takes responsibility for that patient's transition from hospital back to the community, then contacts the patient in the first week to 2 weeks after they've gone home, and even better if they can actually go out and do a home visit and see them in their home environment, and that person also organises any other community care that's required, such as physio or domiciliary nursing, etc. If you have that sort of transition package with one person being responsible and actually visiting and contacting patients after they've gone home within the first few weeks, that seems to reduce your risk of readmission. And I think that is something that we'll probably see more of as time goes by. So there's been about now 4 to 5 trials that have looked at that sort of multifaceted strategy of peri-discharge care, and I think that shows promise. But if you just look at just single interventions by themselves, they don't seem to work very well.
And what are the potential effects of hospital and health reforms on hospital readmissions?
Difficult to say at this stage, because I think the reforms, from my perspective, haven't really gone far enough in relation to primary care and subacute care. I think the reforms have been focused very much on hospitals, although in the recent budget and in some of the more recent announcements from the Health Minister and the Prime Minister, I think they're now starting to look at primary care and subacute care. That is, patients who may need to have some form of at-home rehabilitation, or need to have some day hospital care, or need to have a short time in a step-down facility, so not a hospital necessarily, but some sort of supervised care before they're actually then handed back into the community, and that there's a capacity for general practitioners to also have a greater involvement in the care of patients recently discharged from hospital, and indeed we would like to have GPs more actively involved in the patient's care while they're actually in hospital. But at the moment there isn't financial incentives for many general practitioners to get into that space, and I think that is where more reform is needed to really help us reduce the risk of readmission. So I think it's more access to GPs, to rehabilitation, to respite care, to transitional care packages of one sort or another. I think that's where a lot more work needs to be done in reducing readmissions.
You're speaking at IIR's Reducing Hospital Readmissions and Discharge Planning Conference on the 26th to 27th of July in Melbourne. What will you be discussing in your presentation?
Well, I guess I'll be talking about, what are the factors that predict readmission, trying to identify the most important ones, talk a bit about what models, as I said, of risk prediction people have tried in the past, and what may have perhaps hold more promise in the future, and how we can perhaps collect this information quickly and efficiently in hospital. I'll also be talking about what interventions may be more effective in reducing the risk of unplanned readmissions, and similar to some of the things I've just mentioned. So at the end of the day, I don't think there's necessarily a lot of silver bullets to solve this problem, but I think that there are some promising strategies that we should be starting to look at. But for them to work, there will need to be some change in our current practice, both in hospital and out of hospital, and that there have to be some change, I think, in funding arrangements to allow it to be sustainable over time.
Dr. Ian Scott, thank you very much for your time.
That's my pleasure.